Hi folks, this is Dr. Pickett. This is the audio narrative for the end of the Lecture 2 PowerPoint discussion and the start of Lecture 3 for Bio 401, our clinical literature and ethics class in the MAMS program. I'll be posting this narrative on YouTube and sending you guys the link. So please let me know if there are any issues that you're experiencing in terms of playback. I think if you can play back any YouTube video on your device of choice, you should be able to play back this narrative as well. So when last we met, we were discussing the Tarasoff case and how Tarasoff warnings now have kind of become expected in some states if you're in a situation where you have a patient that has shared confidentially with you as part of the therapeutic encounter an intention to harm others, has named that person explicitly, that you may have a responsibility to break confidentiality and at a minimum directly tell that person, the person who is the target of the threat, that they have been threatened and that they're at risk. So I bring up the Tarasoff case primarily just to highlight the fact that although confidentiality is kind of a baked-in expectation now with things like HIPAA, with many of the care guidelines that professional societies put out, that confidentiality is not a eternal, immutable expectation, that there are a variety of circumstances that arise where you may have a professional obligation or a legal requirement to violate confidentiality. Now, let's kind of ask ourselves this question. If we transition from the Tarasoff slide to the next slide, titled Truth Telling, Why Confidentiality Matters, let's answer that question. Why is confidentiality important? Well, given the goals of medicine, why do we think we need to have truth-telling as an inherent part? Certainly for many years, the physician-patient interaction might not have an expectation of truth-telling. There was an assumption that patients with terminal illness should not be told their situation because there is a desire for the patient to have some sort of abstract hope or expectation of healing, even if they're in a situation in which healing will not happen and they will in fact pass on. So why have we transitioned to a model where confidentiality, truth-telling gets such a high regard in terms of the expectations for physician behavior? Well, obviously truth has its limits at some level. You can say that there's therapeutic privilege. You can say, the physician might choose to withhold some truths, might choose to make a decision to not fully inform a patient at some level. Maybe the patient is suicidal. Maybe the patient has other risk factors that mitigate against fully telling them the truth. But at some level, we really think now that truth-telling is vital, confidentiality is vital, because that is going to improve patient outcomes. It's going to improve their experience of medicine. It's going to increase trust, which will tend to lead to better self-disclosure on the part of the patient. And so if we have confidentiality and an expectation of truth-telling, patients will be more secure in the patient-physician interaction, and with better disclosure, there will be better diagnosis. Medicine as a whole will improve. Because of that, we can kind of ask ourselves, we see in guidelines, you see in practice guidelines, you see in various oaths, a sort of implicit idea that honesty is always the best policy. And I just want to point out that there is in medicine no universal truth standard. There is no one, if you will, reagent grade statement, a command ethics statement about what thou shalt do or shalt not do in terms of telling the truth. It's certainly a best practice. It's certainly an aspiration, but similar to confidentiality, there may be situations in which telling the truth, the whole truth, and nothing but the truth is not the best clinical practice. But assuming we have an environment in which there's confidentiality and truth-telling, what do we hope for? Why are these values kind of paramount? Well, we certainly hope that if patients are honestly informed, they can, if we respect their dignity, if we inform them honestly, they're in a situation where they can deliberate and decide about the care they will consent to in a truly informed way. They have an understanding of their condition. They have an understanding of their options. This is a great situation with a competent patient for there to be informed consent. So at the end of the day, this all kind of comes down to in a situation where the patient is being part of the medical decision-making process, they're conscious, they're competent, they're able to participate, that all of these goods will help the patient make the best decision for them given their own goals of medicine. Breakdowns in this type of relationship where we have to ask ourselves the question, as we did with Sam in our first case, where we have to ask the question, did the patient really understand their situation? Did they really understand their options? Are they in a situation where the medical decision-making that they did really reflects a good informed consent? If there are breakdowns in this area, we start getting into gray areas where lawyers get involved and advocacy gets involved, and you may have to defend your clinical practice in a court of law because you may have done something to someone in a situation in which it is plausible, rational, that they did not truly give informed consent for what you did. Okay, so we've kind of set the groundwork, if you will, for a discussion about informed consent. What are the main requirements overall for informed consent? What are the patient side? What are the physician side expectations for interactions to result in informed consent? Well, to begin with, we have to assume that there's competency or determine that there's competency. What does that mean? The patient is capable of rational thought, deliberation, and decision making. They have their wits about them. If you're in a situation in which language may be a barrier to your ability to assess and query the understanding of your patient, try to fix that so that you really can be sure that the patient is competent and capable of giving informed consent. If you have a situation where you are afraid that it is beyond your expertise, your clinical and professional expertise, to determine whether the patient has informed consent, get help, do a psych consult. You may bring in other type of interpretive services. If you think a patient may have a problem with vision or hearing, it may be that you need other interpretive help to make sure that you are communicating clearly and that your patient can communicate clearly with you. But if they are competent, they are able to participate in medical decision making. The other aspect of a good consenting process is disclosure, i.e., has the patient been informed of the purpose of any procedure? Have they been fully informed about their condition? Have they been told about risks, benefits? In the modern era, I think there is also a responsibility to disclose costs, although even with my own healthcare providers, I discovered that this is often rarely done, in part because costs emerge through a process of negotiation with outside payers, and so hospitals are hesitant to share with you the cost of a procedure on their charge master because it's the rare patient that pays full boat. But many physicians may not know a priori that any individual patient that they see in an emergency room is insured or not. And so there may really be a stronger obligation, especially emerging in the future, that a part of disclosure is this is your illness, these are the things we can do for you, here are a variety of potential options, here are the risks associated with the procedures we'd like to do, the benefits you can expect. This is our best estimate of cost. That would be, in a way, most respecting the dignity of the patient, because we assume that humans also exist as economic animals as well as subjects of our clinical interventions. However, with both of these expectations being met, the patient is competent and good disclosure has been given, we assume now that we have a context for a good consent. If there is limited external pressure, the patient has freedom from coercion, a person in this type of situation can provide voluntary consent, or conversely, they can withhold it. They can say, Doc, I completely understand that what you want to do may be life-saving. My concerns are A, B, and C. I simply don't want to do this. But if we have competency and disclosure, we're in a good situation for at least a defensible statement that a good consent has been given. Now, often patients are in a situation where they simply are not competent. Now, that's according to a technical definition. That might mean that they have, through injury or illness, a severe disability such that their process of mentation is not robust enough to support good medical decision making. They may simply be unconscious or otherwise incapacitated, so gravely injured and in so much pain that it will be difficult to think that they could give rational consideration to anything that you're saying. So if a patient is not competent, in our current system in the United States, another person has to act on their behalf in medical decision making. So if you have a child, an individual that based on their developmental stage cannot be considered to be competent, if you have an individual who is psychotic, unconscious, etc., they certainly cannot be competent in a normal sense. In that situation, we really have to bring in somebody else. If you have a patient who was competent at one point, qualified to participate in their own medical decision making, and they made their wishes explicitly known, hopefully in some written and potentially notarized form, but if not, at least discussed in good narrative detail with health providers or family relatives. If as a care team in interaction with other individuals, perhaps family, the wishes that the patient formally expressed are pursued through the clinical process, i.e., Bob asked us to do this before he fell unconscious. We're going to continue to do it. We described that situation as a substituted judgment. There, we are just transferring the patient's competence in time from a previous period where we were sure of their wishes, we had good consent, into a future period where now they are no longer competent, but we will go ahead and pursue the plan that the patient had already consented to. If the patient's wishes are not known, we have to devolve to a different standard, where we have perhaps a surrogate or somebody else who is acting from a best interest standard, i.e., we don't know what Wilma wanted us to do. We just have no idea, but there's no family here. There's nobody else who might act as a surrogate on their behalf. As a surgeon, I see, given the crushing injury in this woman's abdomen, I am going to go ahead and do surgery to save their life because doubtlessly they have internal bleeding. And if I don't make this best interest decision now, my patient might die on the table as we're waiting to make a medical decision. So when we have a situation where someone is not fully competent, sometimes if we know what their expectations were for care prior to the loss of competence, we can continue on that course. Otherwise, we have to act in some sort of best interest standard. The other possibilities are for things like surrogate consent, where an individual who is a designated medical decision maker, has perhaps durable medical power of attorney, can consent on behalf of the patient, although we kind of think of that surrogacy approach as also being done under a best interest standard. We assume that the surrogate is a person of goodwill who is trying to do what in their opinion is the best for the patient. All right, so we're going to transition to discussing the next presentation at this point. So this completes presentation 2. I'll go ahead and pause at this point and then move to the next presentation, and we can start there with the first slide. Hi folks, so this is the next presentation, Lecture 3, covering material in chapters 3 through 5 at some level. I call this Roles and Responsibilities 2. Note, I also indicate that there is a case discussion, but of course in the context, unfortunately, of this online slide narrative, we will not have a case discussion until we meet again next week after the cold lifts. Let's talk a little bit about exploring physician roles. Talk now in an expanded sense about all of the responsibilities that physicians may have and the things that they bring to the care encounter. We think that there are definitely practical roles that physicians have, so I'm beginning on the slide exploring physician roles. I believe that is slide 3 in the slide deck here. So to begin with, we can kind of say, well, their roles are very practical. A physician has a role in diagnosis, in assaying the patient's presentation, doing a basic workup of the case, trying to assess things like primary complaint. If they can get better diagnostic information, they may do things like order tests, doing all these types of things that are the practical side of the clinical encounter. So this is diagnosis, things like care coordination and management. We now really are trying to think about how physicians will be projecting into the future. We know that physicians will have declining roles in the direct patient encounter simply because we know we're developing a staffing crisis in medicine, and particularly in primary care, are getting to a situation where there will be a smaller number of physicians available to assign to all of the necessary care encounters or clinical encounters. So that means physicians will increasingly be transitioning towards situations where they're coordinating the care of a team of nurse practitioners. They're coordinating the care of a team of physician assistants. Although they will certainly be seeing patients, every clinical encounter is not going to have the doctor as the medical decision maker, the provider of medical therapy in the room every time. Oftentimes, those providers may be physician assistants, nurse practitioners, or nursing staff. So we now think, yeah, absolutely, the physician is going to be doing classic doctoring, but will also be moving into this small team management role as well. In that role, the physician will definitely be playing an important role in the treatment plan. They may not be initiating the treatment event, but they will certainly be planning the care. They may be suggesting physical or drug interventions, various types of assessments, ongoing telemetry, ongoing testing, making sure that the patient's condition is stable or improving and not declining. The physician plays an important role in team management, leadership, also in compliance, making sure that practice guidelines are satisfied, the guidelines for care in the hospital are satisfied, and that legal and ethical standards are met. Now, another thing that the physician probably has an important role in is in helping maintain high ethical standards as part of the care cycle. What does that mean? Providing education and mentoring to other team members. We don't think necessarily about physicians having a role as trainers in the day-to-day, physicians who are academic physician scientists in academic hospitals. Absolutely, they're always going to be rounding with their residents. They're always going to be rounding with interns. They're going to be teaching medicine. But an element also of education might be helping your PA, making sure that the PA has the best understanding possible of a new pharmaceutical intervention that's recently come into the hospital. You want to get your care team in the emergency room together for an in-service training about a new drug that's going to help support the care of a individual that has a traumatic injury. Consenting, we think of as very important in terms of the physician's role. Has the physician creating the context for a good consent? Has there been disclosure? Has there been assessments of competency, etc.? Physicians certainly play an important role in medical decision making. Some of that can also have an ethical component as well. They have an important role in truth telling, helping to make sure that the patient understands the truth, the reality of their situation, and also that the patient understands and the clinician understands that there will be respect for confidentiality in the relationship that is occurring in the clinical encounter. So obviously these kind of practical, ethical, other potential considerations, other realms overlap. And so let's do a little bit of a deeper reflection on roles and communication. So Charles and his fellow authors kind of have come up with an idea about classifying different qualia, different qualities of medical decision-making processes and comparing perhaps historical processes, current processes, as a way in a comparative fashion to see if we can kind of land on a medical decision-making process that might be best in many circumstances, if not universally applicable. So their decision-making processes kind of boil down into three broad models, which I've kind of illustrated with little Wikimedia images. The caduceus, the physician, with an arrow pointing at the patient. This has kind of come to be shorthand for a paternalistic interaction. The physician decides and then treats. The other image we have where there is a caduceus and an arrow leading to the patient, but then there's feedback that's coming from the patient. This is often seen as an informed situation where the physician may be advocating for roles, giving lots of education, trying to develop the context for a good consent, allowing the patient to have some feedback, but the physician is probably going to use their best medical decision making to help the patient narrow choices so that they will have the most effective medical experience given the clinical experience of the physician who is offering advice and a plan of care. The last image on this slide for Charles et al. Decision making shows a caduceus and a patient with an arrow going in both directions. This is a reference to the shared decision-making model where there are many rounds of exploration. The patient is continually querying the physician. The physician is always bringing in new data. And so the medical decision, a consensus, emerges over a very extensive process of reasoning together between the physician and the patient. So these can kind of be summarized here in the next situation. If we think about at kind of the analytical level, what type of information exchange there is, how information flows between the physician and the patient, and then ultimately how the medical decision is made. So if we start out thinking about information exchange and we think about how it's flowing, in a paternalistic system, the information flow is largely one way, i.e. the physician is giving information to the patient. That information may primarily be medical, and under kind of classic paternalistic models, there was an idea that the amount of information would kind of be the minimum that the physician felt like was useful to the patient, and perhaps the minimum information that would protect the physician from any future legal challenge. In a highly paternalistic system, who's the decision maker? Ultimately, the physician is. Now, the physician may call for other consults. There may be other physicians whose opinions weigh in. But at the end of the day, the decision to treat, the full extent of the treatment plan, that decision lies with the physician. In a shared model, we have a situation where the flow is two-way. The physician is bringing information. The patient is sharing a deliberation process, is sharing a process of choosing alternatives. In this situation, under a shared model, a lot of different types of information is occurring. It may be medical information, there may be personal information. The patient may be saying, I can't come in for surgery because I haven't arranged or been able to figure out how to arrange for care at home. By sharing that information, the physician may be able to say, we can connect you to a social worker who can connect you to these resources. The hospital has ways of helping you get home care. That type of sort of shared deliberative decision-making process requires information exchange in both directions. In a shared model, all of the relevant potential information that could possibly impinge on any type of decision is shared. The deliberation process includes the physician, the patient, plus potential others. There may be family members involved. If they want to weigh in, the physician may call in for other physician consults. And at the end of the day, the medical decision will reflect a contribution to the decision-making process of both the physician and the patient. In a classical informed decision-making process, basically the physician is the oracle providing medical information. The physician is primarily kind of unidirectionally flowing information to the patient. The patient then may share feedback, but in a pure informed model, the patient will ultimately be the medical decision maker. What the physician is doing is saying, given my medical expertise, I know that there are 5 possible alternative treatments. Given the hundreds of patients I've seen over the last 20 years, 2 of those treatments seem to have good results in my patient population. One has a slightly longer recovery period than the other. What do you want to do? The patient then says, I'll take one from column A, one from category B, and then the physician goes ahead and runs the care process. Now, it's interesting when we evaluate sort of different types of practice. Are practices more paternalistic? Are they more shared? Do they have more an informed character? Is a pure shared model where we might spend days deliberating about whether or not, or months deliberating about whether or not to have the surgical resection of a tumor, although that might create a great kind of community experience for the physician and the patient, we don't know if that would necessarily result in the best decision-making process. Is an informed model enough? Should we be leaving decisions primarily with patients, even if they're incredibly well informed and benefit from medical expertise in which the physician is presenting a hierarchy of different alternative interpretations? But anyway, those are kind of the 3 models that I think people think about now and are kind of applying and thinking about, can we make a decision-making process less paternalistic? Or is this a medical decision-making process in which, in effect, the stakes are low, the results are so trivial? Paternalistic approaches speed up the cycle because really patients have very few good options. The only option that is available is the one that's FDA approved. We would certainly like the patient to either decide or not to allow us to continue on with this treatment, but there really isn't much of a decision to make. Basically, what I need to say is, you have minor pain. The best thing I can give you is a non-steroidal anti-inflammatory. All of the other possible choices, opiates, a spinal block, etc., simply are not indicated in this situation. Okay, so now let's kind of talk about some of the supports for good decision making. How do we get to one of these good medical decisions, depending on the process of communication that we use? Siegler kind of comes up with this idea again, revisiting confidentiality. This is the expectation that complaints, diagnosis, treatments, and outcomes will remain confidential. This has been enshrined in HIPAA. We know, as I've discussed previously, that this is certainly an aspiration. It's a best practice, but it is not an absolute. Why? There are many parties who do have legitimate rights to know. Your insurer has a right to know about the treatment that you've received because they're being expected to pay for it. In a situation where there may be many individuals that have a right to know, is confidentiality in a strict sense still valuable? I.e., do diverse members of society at large have a right to know? I.e., if you have a genetic disease, do your children who may be at risk of having the disease or of being carriers of a disease allele have a right to know about your status so that they will get themselves tested? Should society at large have a right to know about the frequency in a population of which disease states arise, so the population as a whole can better plan for the costs of care in individuals who will be affected, or for apportioning research resources so that new drugs will be developed? If we have no knowledge about how frequent a disease is in a population, how can we possibly plan for it? So we certainly think that confidentiality is important. It may become increasingly conditional based on other individuals in the population having a right to know about individuals' health status. We've already discussed a little bit about some of the other goods that adhere to the idea of confidentiality. Trust is important because of presentation and diagnosis. Transitioning to the next slide. If we don't have a good diagnosis because our patient doesn't fully reveal the situation, we may do a treatment plan and diagnosis that's incorrect. Thus, there will be an outcome mismatch of treatment with disease, because we'll think the person has chicken pox when they really have shingles, because they haven't let us do a full physical examination because they didn't trust us enough to do that. So obviously respect is important because it embraces patient and provider dignity and may ultimately lead to better care. So let's talk a little bit about some of the conflicts that can arise when we consider a concept like confidentiality. There may be situations where patients have a diversity in terms of their legitimate interests. They may have a desire for privacy that would tend to privilege confidentiality. It is a good to me that other people are not gossiping about my health conditions. But if limiting my confidentiality would encourage my physician to reach out to more specialists, or to bring up my case, hopefully de-identified, but my case at a public lecture where a national expert in my illness is giving a presentation and might be able to give a special expert consult, there might be a conflict between my desire for privacy and my desire for a best outcome from treatment. If my privacy is perfectly respected, the best diagnostic plan, the best treatment plan may not be developed that will give me the best outcome. We now really think that team-based medicine does promise best outcomes. Why? Because every individual will have access to the electronic medical record. My nurse will know that I've already been dosed with one dose of my drug and will not mistakenly give me a second dose. But she wouldn't know that if there wasn't some suspension of confidentiality, if she didn't have a broader view of my care plan than might historically be the purview of nursing staff. Also, as I've discussed previously a little bit, medicine is obviously expensive. Insurance companies feel they have in-depth review rights, up to and including the ability to, prior to treatment, discourage or forbid you from receiving a treatment that the insurance company believes will harm you or will have no effect on your case. Also, we now think that there are a variety of other situations where confidentiality could present a potential barrier to better care. If you're going to require family supports, maybe your family should really be brought into the discussion of the extensive and debilitating surgery that you're going to receive, because they need an opportunity to plan for your care. There can be a variety of different situations where we could say a suspension of confidentiality could potentially be justified. Um, so how do we think kind of confidentiality is going to evolve in the future? I'm still kind of transitioning from Siegler's work here and also talking about some of Erickson Millar's work. Um, Modern institutions definitely believe that confidentiality is a good that they want to privilege, but they also want to benefit from things like team-based medicine, from electronic medical records in which a physician's orders might be available to a wide variety of individuals in a clinical setting, because that would contribute to better coordination of care. Now, then the question is, does nursing staff need to know every aspect of a patient's medical record? Do they need to know every aspect of a patient's medical history? Or maybe should there instead be a need to know standard, where we maybe have the medical records partitioned into different areas of knowledge, and for instance, all of the treatment plan germane to nursing is made available to nursing staff. All of the treatment plan germane to transport is made available to the transport staff, but other information is held in reserve to help enhance the patient's confidentiality. The need to know standard that I think a lot of hospitals would like to transition to, maintaining as much patient privacy as possible while also leveraging the value of team-based medicine, is a fairly high standard. It's higher than FERPA. It is a stronger standard, in fact, than now exists in academia. HIPAA certainly may help. Electronic records may be more easily compartmentalized. Also, asking the patient, what do they want from confidentiality? What does confidentiality mean to them? What information do they feel should not be discussed? Is there a way we can kind of cloud that out in a medical record while giving all of the care team as much access as possible? A new standard that is emerging is the idea of allowing patients to review and potentially censor their electronic medical records if there is something that they consider deeply embarrassing, a diagnosis of a sexually transmitted disease. Well, that diagnosis may not be something that every care member on the team needs to know about to make sure that the team is giving appropriate care to the patient, that the patient is benefiting from that care, and similarly that the patient is being treated in a way where they are not presenting a potential, let's say, infectious disease risk to staff. So, where do we think kind of confidentiality is at risk in big medical environments? Well, we think one area where it's at risk is under the phenomena of gossip. These have euphemistically been called hallway consults, where residents are getting together over coffee and discussing, without de-identifying patients, sensitive or embarrassing information. The hallway consult is a real problem. It's part of the culture of medicine. It's something that all physicians, residents, and students should be aware of. Just as a reminder, professionalism does not stop at the door of the patient's hospital room. Individuals should be sensitive to locale, the composition of the social group, etc., before discussion commences. If you can at all possibly do it, de-identify any discussions that you have, obscure details, remove names. That can be important because teaching is not gossip. Giving patient cases, giving case discussions, having a clear, open discussion in morbidity and mortality meetings is incredibly valuable for the learning process the evolution and development of science and medical education. But you can increase confidentiality and respect by, for instance, anonymizing cases. When you're working with records, are all of your records password protected? When you walked away from the computer, did you put it on the lock screen? If you're using paper records, are you throwing a paper record away in the garbage, or are you making sure it goes into a secure shredder? So I think these are questions that are kind of arising now in sort of a practical sense in medical centers. How can we create a culture of respect for confidentiality? How can we support each other in developing good communications around confidentiality? So the last thing I'd kind of like to discuss a little bit more is this idea of truth telling, because, if we look at MDTV, we talk a lot about truth telling from the perspective of physicians communicating to patients, but that isn't the only situation. Physicians and patients have a responsibility in a two-way sense to tell the truth. If you are in a clinical relationship, in a clinical encounter with a physician, there should be an assumption that the patient isn't lying to the physician, as well as vice versa. Physicians may also have responsibilities to other interested parties. They may be required to tell the truth to research funders, to tell the truth to hospitals, to communicate truthfully with the healthcare team, and to communicate truthfully with care funders. Why is this an issue? In recent surveys done over the past 10 years, approximately a third of physicians report using deception to secure cost recovery for the benefit of a patient that has needed care that they can't pay for, to try and find a way to get them the care they need at a reasonable price. It's interesting because when you query the broader public, many patients, the patient community, suggest that they're comfortable with that they'd feel supported by a physician who would lie for them to get them care. What's the problem with this? It introduces error into the medical record. If you're reclassifying a patient's illness to get them, for instance, access to a drug or therapy, that patient's illness status now will continue to endure within the electronic medical record. This may result years in the future to misdiagnosis and mistreatment by somebody that goes, oh, this individual had cancer at one point, when really they had a benign neoplasia. You may have had a concern about how that disease was treated. You may have given a stronger drug than would be on the formulary, the approved drugs list of the insurance company, and now you have a patient where everybody else is going to be doing cancer surveillance, because what was really benign neoplasia you characterized as a cancer that was excised. So this is a difficult issue and also supports truth-telling. So when we're telling the truth, what are some of the other considerations that we can think about? There are ways to communicate with patients that may promote healing. We may want to balance hope, mentoring, education with realism. We may want to try to suggest potential alternatives, give a variety of different scenarios, even if a patient is in a very severe state, is unlikely to recover. If patients have recovered, it may be useful to say it's only 10% of the cases, but some of our cases do recover. Now, balancing this idea of wanting to provide hope, we also want to be careful that we don't abuse hope. American physicians have have a reputation for positivism, that if there's any possible silver lining, many physicians will have a tendency to present that as a potential or even likely outcome. That means, from a certain sense, there can sort of be a pressure to hope. Also, this phenomena of American positivism can reflect back on patients, where patients may feel like they are not respected in their own feelings unless they present a very upbeat, very forward looking view, maybe don't have an opportunity to reflect sadness about a situation that they're dealing with, honestly share their level of pain, etc. So, measures of happiness are interesting. When we look at healthcare, it's quite fascinating. Although broadly Americans are quite positive, we report fairly high happiness and satisfaction rates. We report fairly low satisfaction and happiness rates with our healthcare and the quality that we receive. There is a influence on patients and clinicians with this cultural ideology of positivism, that as a culture, we want people to be forward looking. There is a pressure to be upbeat about your situation, even if you're very sick. Physicians may feel a pressure to be upbeat in their diagnosis, even if a patient is very sick, because of this kind of cultural drive, this force towards positivism. It's interesting because there may be a value to this because of the placebo effect. It is possible that having a positive and hopeful outlook about the recovery or the improvement of a subjective endpoint like pain, discomfort, fatigue, sometimes wishing may make it so. If we're positive with the patient may actually experience a better outcome because of the placebo effect. But we have to be careful as well, because spending all this time being positive, maybe discouraging patients from sharing the full extent of their pain, maybe pressuring patients to be optimistic about the outcome of a treatment, we might be kind of stealing time cycles away from valuable, let's do something. I'm really in pain. I need some help, or my quality of life is going to significantly decline. I'm not going to lie to you about how much pain I'm in. I'm going to seek help. I want you to really help me. If we spend a lot of time going, oh, I'm fine, doc, being stoic, we're kind of wasting time in the service of a positive idea rather than using valuable doing something time. So, we think that hope and realism is important. It certainly is different than pessimism. Having a realistic idea about our necessity for forward planning, a realistic idea about the fact that we have a life-threatening disease, but having some hope about it, that's important. We may still want to do planning, getting our affairs in order, potentially meeting with loved ones, making sure that we're clearly communicating our feelings with individuals who are important to us. That doesn't mean we can't be realistic about our condition, but that's different than kind of being pessimistic. We can combine hope and realism in a positive way without necessarily falling into pessimism. One thing that patients repeat routinely is that they want their fears validated and explored. They want their pain understood and treated. They want space from physicians to share with them their fear, their anguish, their uncertainty. They don't want the physician to just say, everything's going to be fine, pat on the hand, moving on to the next patient. They really want their concerns, fears, pain, cautious view of the future, to be validated and to have the opportunity to explore that with physicians. This can be hard for physicians because this suggests that real empathy may require hearing bad news from patients. This kind of love bombing approach, stay positive, breast cancer patients, stay positive, terminal lung cancer patients. This can, in a way, cause a loss of empathy, a loss of understanding, because the patient doesn't have room to respond. But I'm not positive, but I'm in pain, I'm very sick. I don't want to be positive. I want to spend some time grieving. I want to spend some time reflecting, thinking about the issue that's happening. Having patients all the time hearing from providers, stay positive, you're getting better, etc., etc. This can also be a way of saying to the patient, I don't want to hear about your problems. This kind of love bombing approach is a way of shutting off, shutting down patient opinions. Now, this has kind of been described as the empathy deficit, sort of pasting over real problems with happy talk. I just want to encourage you to give patients what they really need. You owe them hope and realism, but you also should leave them space to grieve, to share doubts, to ask questions. Don't shut them off with kind of happy talk, fake positivism. Now, breastcanceraction.org is interesting because they talk about giving breast cancer patients the opportunity to experience their real emotions, that's an important part of both the disease process and the healing process. The Pink Ribbon campaign kind of also talks about this as well, that breast cancer patients shouldn't be love bombed, forced into positivism, but they should be given an opportunity to be respected for the real feelings and real experience of the disease that they're having. Okay, so now let's explore informed consent a little bit more deeply and see what some of the issues are that adhere to informed consent as it's actually practiced. This is some of the work of Brody. So we do think that the daughter of truth-telling kind of is informed consent. What does that mean? If a patient really understands their situation, that disclosure is important and supports a patient's informed consent. Now, it's interesting. In the absence of disclosure, a patient may not be able to give informed consent. That does not mean that they are incompetent. They're competent, they just have not been fully disclosed. They don't really know their full situation. So sometimes students kind of mesh those ideas together. Oh, well, if there wasn't informed consent, the patient must not be competent. No, a fully competent patient, if they were not informed, may not have been able to give a good consent, but that doesn't mean they are incompetent. Disclosure does not impinge on a patient's competence. It impinges on a patient who is competent's ability to provide informed consent. We can ask ourselves this question: how well established is informed consent as a practice? It's fascinating because in surveys we do think that there is a special deficit in primary care. Why? We think primary care physicians often default to quite highly paternalistic approaches. The reason: time pressures are certainly important. If you have 12 minutes to see a patient, you as a well-meaning physician want to get them the most help you can, understand the most about their diagnosis. Many times in a primary care situation, toe fungus, we know how to treat athlete's foot. We're going to look at it. We're going to see cracked skin. We're going to say, Wilbur, I know exactly what you need. Here's your Desinex. Here's your athlete's foot fungus treatment. Be on your way. Be on your way. In part, we think that the primary care environment is more paternalistic because generalists may not know all of the possible treatments, but they may have treatments that they rely on routinely. They may also find that the stakes are somewhat low, i.e., athlete's foot's just athlete's foot. We're not talking open heart surgery here. So it may not be surprising that there is a fair amount of paternalism in primary care, but primary care physicians should be aware of the fact that some of their medical decision-making approaches could be viewed as very paternalistic if they don't use a more informed approach, trying to solicit some patient feedback. Certainly, we think that payers also play a role in how paternalistic primary care is because payers aren't giving doctors much time. So, how is informed consent viewed from the perspective of the different parties involved? There are some basic assumptions. Physicians in surveys do tend to view informed consent as a legalism. It's a box to check. It's a script to go through in the electronic medical record prompt. Then you check the box and you're done. That situation has led to a tendency to disengage a bit. The disclosure aspect can be very brief. Patients report that the quality of the disclosure that they're receiving from physicians has been declining over time. And so if physicians do view consenting as simply a legal formality, there may be a tendency to kind of gloss things over, just get to the point where we can click the box and move to the next screen. Also, there may be a tendency to disengage from communication because the physician is firmly convinced that the treatment that they always do, using surgical mesh to repair a hernia rather than more complex surgery, since that's what they always do, it's the best approach. It doesn't make any sense to disclose other alternatives to patients because this is just the one best approach. In surveys comparing patients and physicians after a consenting event has occurred, it turns out that there is a disconnect between patient expectations and what physicians provide, i.e., patients have a real desire for knowledge. They really want to have a role in their decision making, and physicians will often report saying, I didn't really see that they were that concerned about anything. I'm surprised now hearing after the fact that this patient did not feel they had a good consent. Let's talk about consent from sort of a legalistic perspective. What are the different, if you will, legal standards for a good consent that have come to fall into practice when we're talking about physicians feeling that they have done a good consent? Physicians have often resorted to what's called a community of practice standard for consent. What does that mean? I behaved as other physicians behave. So under a community of practice model for giving a good consent, as long as a physician discloses, informs, interacts in a way that other physicians in the practice do as part of the consenting process, a standard of care has been met for consenting, the physician should feel confident that they gave a good consent. What's the problem with this community of practice model? What if the community has a very poor standard? What if universally across the group of ear, nose, and throat doctors, a culture of practice has developed in which consenting is done fairly poorly. That's difficult because it turns out in legal cases this has not been a particularly strong defense. Although physicians will say it must be okay as long as everyone's doing it, juries and lawyers have made compelling cases that this is a fairly poor standard. You would see almost universally now this standard is no longer taught as a good way to do informed consent. Just saying, I've done consenting the way I was taught, I've done consenting the way the other members of my practice do it. That's not a very good defense about a poor consenting process. Another standard that physicians have used is this idea of the reasonable patient standard, i.e., have you done your very best to explain and disclose given a reasonable patient, assuming a patient has passed some threshold for competence, some threshold for understanding language, some threshold for reading interpersonal cues. Given that sort of reagent grade average patient, what I did would have satisfied that patient. This is an interesting idea. The problem here is the reasonable patient is an abstraction. Every patient is in some sense unique. And so just saying, well, I've done something that any reasonable person would understand doesn't mean the patient before you did understand. So there are a variety of different issues that kind of adhere to this idea about consent and different models for how to get good consent. What are some of the problems that come up with? Can a primary care doc know all alternatives, risks for hundreds of treatments, etc.? No, inevitably they're going to go with things that they're fairly comfortable with. That could be old technology. That could be superseded ideas. And so, unfortunately, if part of the disclosure process does not include a physician that has good continuing medical education, a physician that has an intent to truly communicate, a reasonable patient standard and a community of practice standard, these both can be fairly weak standards for getting good consents. Now, what are some of the more modern models? The conversation model. In this case, there's discussion, exploration. This is kind of analogous to the shared model for medical decision making. Doubtlessly, these could result in wonderful consents, patients fully informed, all of their doubts explored, all of their questions answered, an opportunity to revisit on different occasions, alternatives, alternative treatments, alternative drugs, etc. A patient so well informed, having had lots of opportunities to share how they perceive and understand any potential treatment through the questions that they ask their physician. If that patient signs off on something, that's going to be a great consent. But it can be difficult to operationalize, as we've discussed about a sort of a pure shared model, simply because these cycles of communication, repetitive cycles of communication time and time again, can be very time consuming. So I would say a modern standard that many practices are kind of landing on is a transparency standard in terms of getting good consent. What does that mean? Physicians discuss their reasoning for a proposed treatment. The patient asks questions. One of the questions that the physician will ask is, could you please repeat to me what our treatment plan is together? Define it in your own terms so that I can be sure you understand it. That type of communication, being transparent, saying there are a variety of alternatives, but this alternative I believe is best. Now that we've landed on a plan of care, Can you tell me in your own words what this plan of care is? That type of approach can be relatively quick, have good disclosure, and the patient is, in a way, displaying their competence and the quality of their consent by placing in their own words what the treatment plan is. So more and more physicians are adopting the transparency standard. This is why interviewers want to hear you think out loud. They want to hear you in an interview for medical school be somebody who can think on their feet, be engaged, interact, share knowledge, listen, reevaluate, share new knowledge, opinion, understanding. A transparency standard requires good communicators. This is why medical schools really are looking in part for individuals who are confident, great communicators, and why the interview has these types of characteristics. So anyway, my friends, thank you very much for your attention. I'm bringing it in just around 70 minutes. So hopefully this will satisfy you as your surrogate for our Thursday meeting. Please stay warm out there. Please stay out of the cold. Bundle up with some nice hot chocolate or a hot tea. Study your biochemistry. I did get some emails from some folks that were having a few problems submitting. Don't worry about it. We'll handle that. Send me emails if you have any documents that you weren't able to upload. I'll definitely look at everything. I'm not going to be calling materials as late. We'll go through and we'll do a tutorial, and we'll just see if maybe in lecture next Tuesday we can try and get folks a little bit more comfortable with the submission process. But anyway, thank you for your attention to this slide narrative, and I hope it's useful to you. I'll see you again next Tuesday. Next Tuesday we will be starting to do a case, which unfortunately I'll have to distribute at that time. I was hoping to distribute it on Thursday, so I'll give you guys a little bit of time to review the case, and then we will transition on to our next discussion at the start of week 4. Also, good luck with your guys' first set of exams. Have a good day. Bye-bye.